It's a Tuesday morning somewhere in East Africa, 1993. The air is already hot before the sun's been up an hour, and it smells like red dust and diesel and the particular emptiness of being a very long way from home. A medic works his way down a row of tents with a cup of pills. One per person, don't argue, don't ask questions. Malaria country. You take it or you risk dying in a fever. The soldiers took it. Every Tuesday, every single week. They didn't know what they were taking or what it was doing to them. They started having nightmares, not the normal kind, but vivid and physical and almost real enough to taste. They started calling those nightmares Meflemares, and they started calling Tuesdays Psycho Tuesdays, not as a joke, as a warning to each other about what came next. The drug was called Mefloquine, brand name Lariam. The U.S. Army developed it, tested it on prisoners and soldiers in developing countries, handed it off to a pharmaceutical company to sell, and then spent 24 years ordering hundreds of thousands of its own troops to take it, while ignoring clear evidence that it was doing something permanent and terrible to their brains. This is that story. To understand how this happened, you have to understand what malaria did to the U.S. military in Vietnam. Malaria isn't just a bad fever. In its worst form, it shuts down organs and kills you. By 1967, it was sending more American troops out of the field in Vietnam than enemy fire was. The parasite had developed resistance to chloroquine, the main drug the military had relied on for decades, and without an effective treatment, men were coming out of the jungle in serious trouble. The Viet Cong had access to Chinese-made drugs that worked. The Americans didn't. So the Army tasked Walter Reed Army Institute of Research, the military's top medical lab, located in Silver Spring, Maryland, with finding a solution. Researchers there screened more than 250,000 chemical compounds looking for something that would kill a drug-resistant parasite. After years of work, they found it. The military's internal designation was WR-142490. The world would come to know it as Mefloquine. The Army couldn't bring a commercial drug to market on its own, so it partnered with the Swiss pharmaceutical giant F. Hoffmann-La Roche. Roche would manufacture it, brand it as Lariam, and sell it commercially. The FDA approved Mefloquine in 1989. On paper, it looked close to perfect. One pill every week instead of one per day, effective against the strains that had beaten chloroquine, affordable enough to give to everyone in a theater. By the early 1990s, it had become the U.S. military's standard drug for malaria prevention across sub-Saharan Africa, the Middle East, Central and South America, and eventually Afghanistan and Iraq. Hundreds of thousands of service members would take it over the next 2 decades. The problem was the label. The FDA label for Mefloquine, the official guidance required by federal law, was explicit about who shouldn't take it. People with a history of depression, anxiety, psychosis, or seizure disorders were flagged as high risk. If someone started showing psychiatric symptoms after taking it, nightmares, confusion, paranoia, agitation, the drug was supposed to be stopped immediately. And it specifically noted that Mefloquine should be used with extreme caution in patients with prior traumatic brain injuries, because the drug crosses the blood-brain barrier and behaves differently in an already damaged brain. That guidance wasn't new. It wasn't a later discovery. It was in the product insert from the very beginning. There on day one, before the first soldier ever swallowed the first pill. Dr. Remington Nevins served as a preventive medicine officer in the U.S. Army. He deployed to Afghanistan with the 82nd Airborne Division. After his service, he spent years researching what Mefloquine actually did to the people who took it. And he's been more direct about the military's failure than almost anyone else who's spoken on this subject publicly. He described the standard approach to Mefloquine distribution in the military like this. Here's your Mefloquine. You're getting on the plane. You may have some crazy dreams, but suck it up and drive on. And then he added, We systematically ignored and undermined the critical safety warnings in the product insert. There was no psychiatric screening before the drug was handed out. Nobody checked for contraindications. The FDA required that every patient receive a medication guide explaining the risks. That didn't happen consistently in military units. The drug was supposed to be logged in each soldier's medical record every time it was prescribed, and in many units, it wasn't. Soldiers who experienced symptoms and tried to report them were sometimes told these symptoms were just a perception and to keep taking the pill. This was the institutional framework. The assumption built into it was that troops would comply, that the Army knew best, and that the psychiatric warnings on an FDA label didn't really apply to people whose job involved going into combat. The idea that a weekly pill given to prevent malaria might itself cause permanent damage to the brain wasn't something that got much airtime. Early pre-licensure testing on the drug had been done largely on male prisoners, military personnel, and subjects in developing countries. Vertigo and nausea showed up in those trials, but the drug was considered largely free of serious psychiatric effects. The later neuropsychiatric picture, the one that would emerge over the next 2 decades, wasn't yet fully visible when the FDA approved it. But the warnings were there. They just weren't followed. What that looked like in practice was a medic walking tent to tent with a paper cup. No conversation about what you were taking or what it might do. No questions about your medical history. No signature on a form that said that you understood the risks. Just the cup, the pill, and the expectation that a soldier did what they were told. Across the Army, across the Marine Corps, across the Navy and Air Force, hundreds of thousands of times over 24 years. That's how it went. A weekly ritual that barely rated a mention in anyone's day, and that was reshaping the brain chemistry of a meaningful percentage of the people going through it. In late 1992, Canada sent roughly 900 soldiers from its airborne regiment to Somalia as part of a United Nations peacekeeping mission. They were given mefloquine on a weekly schedule. Nobody discussed the side effects. Nobody asked about mental health history before handing out the pills. The doses came on Tuesdays. Greg Janes was a medic with the regiment. His job was to make sure everyone took the pill. He later described what he witnessed after those doses. Soldiers screaming in the night. Men walking out of their tents at 2 a.m, unable to say where they were going or why. A kind of disorientation that didn't lift until a day or 2 had passed. The unit developed a name for it, Psycho Tuesdays. They called the nightmares meflomares. Janes himself came home with symptoms he carried for decades. Insomnia, hypervigilance, what he described as hair-trigger aggression. More than 25 years later, he said he'd never be able to fully come back to who he was before Somalia. That mission ended in a scandal that shook Canada to its foundation. 2 soldiers from the regiment were charged with torturing and beating to death a 16-year-old Somali boy named Shadane Aron. His cries for help went on for hours while other soldiers nearby heard them and did nothing. At the inquiry that followed, investigators asked specifically whether mefloquine had played a role in what happened. They couldn't prove that it did. They also couldn't prove that it didn't. On the American side of things, the warning signs kept arriving, and the military kept not connecting them. The summer of 2002 changed that, or should have. Fort Bragg, North Carolina, is home to some of the Army's most elite soldiers. Special Forces, Delta Force, Civil Affairs, Rangers, they're all there. That June and July, 4 soldiers stationed at Fort Bragg killed their wives in the span of 6 weeks. On June 11th, Sergeant First Class Rigoberto Nieves, who'd been back from a Special Forces deployment to Afghanistan for exactly 2 days, shot his wife Teresa and then turned the gun on himself. On June 29th, Master Sergeant William Wright, home from Afghanistan for about a month, strangled his wife Jennifer and buried her body in a shallow grave in Hoke County. On July 9th, Sergeant Cedric Griffin stabbed his estranged wife Marilyn more than 50 times and set her house on fire. On July 19th, Sergeant First Class Brandon Floyd, reportedly a member of Delta Force, shot his wife Andrea and then killed himself. 3 of the 4 had returned from Afghanistan. All 3 were reportedly on mefloquine during their time in country. 2 more of the soldiers died by suicide before they could ever stand trial. The Army dispatched a medical investigation team to Fort Bragg to look at everything: deployment stress, marital history, pharmaceuticals. The conclusion? Pre-existing marital problems were the most likely cause. Mefloquine was listed as an unlikely factor. The pattern didn't disappear, it just kept accumulating. Here's what made mefloquine so dangerous and so easy for the system to ignore. Its symptoms look exactly like something else. Vivid nightmares, tinnitus, that constant ringing that doesn't stop, vertigo, anxiety that doesn't respond to treatment, paranoia, depression that won't lift, trouble concentrating, trouble finding words you know perfectly well you know, suicidal thoughts, a personality shift that your family notices before you do. These are the documented symptoms of mefloquine toxicity. They're also the primary symptoms of PTSD and traumatic brain injury, 2 diagnoses that were already running through the veteran population in massive numbers by the mid-2000s. So a veteran came home from Iraq or Afghanistan with all of those symptoms, and a VA doctor gave them the diagnosis that fit the picture: PTSD. They went into therapy. Some were put on medications. Many of them didn't get better because the standard treatment for PTSD doesn't address a physical injury to the brain. And that's what researchers like Dr. Nevin concluded mefloquine toxicity was: not a psychological reaction to stress, but a physical one. Mefloquine crosses the blood-brain barrier in a meaningful percentage of people who take it. It damages the regions of the brain responsible for balance, sleep, memory, and emotional regulation. That damage doesn't reverse when you stop taking the drug. It doesn't fade over time the way a normal drug side effect might. Dr. Nevin and other researchers eventually gave it a clinical name: quinism. Quinoline encephalopathy, a drug-induced brain and brainstem injury. The misdiagnosis problem was made worse by what happened to the records. Because the military hadn't consistently logged mefloquine prescriptions in soldiers' medical files, veterans who tried to file VA disability claims found themselves without the documentation they needed. By January 2012, the Pentagon's own internal memo acknowledged that some troops had been given mefloquine without it ever being entered into their medical records, which meant the VA had an easy answer when veterans came forward: there's nothing in the file. The burden of proof landed on veterans who'd taken the drug because they were ordered to, with no ability to refuse, no meaningful warning about what they were swallowing, and no record that they'd taken it, because the institution that gave it to them never wrote it down. Navy Commander Bill Manofsky was medically retired in 2004 with neurological problems he linked directly to mefloquine. He became one of the first veterans to successfully receive a VA disability rating connected to the drug, and he later became an advocate for others navigating the same fight. He described what he consistently heard from the veterans he worked with. All have been misdiagnosed with PTSD, but it's a physical injury to the central nervous system. And then he said something that's hard to shake once you hear it. Talk therapy does nothing for mefloquine poisoning. The VA just keeps saying it's PTSD and throwing drugs at them. In 2009, the Department of Defense quietly changed its policy. Mefloquine was no longer the first choice for malaria prevention. Doctors were told to try doxycycline and ativaquone proguanil first, and only turn to mefloquine if those options didn't work. The shift happened without any public acknowledgement of harm. No statement about what had been done wrong. No outreach to the hundreds of thousands of troops who'd already taken it. Just a change in the guidance documents. 3 years later, the story got a face most of the country knew. On the night of March 11, 2012, Staff Sergeant Robert Bales walked off his base at Camp Bellenby in the Panjwai district of Kandahar Province, Afghanistan. He was on his first Afghanistan deployment, following 3 previous tours in Iraq. He walked to a nearby village and killed 4 people, including a child, then came back to base for more ammunition. He went out again. He walked to a second village and killed 12 more people, mostly women and children, most of them in their beds. He buried some of the bodies. Bales pleaded guilty in 2013 to avoid the death penalty and was sentenced to life without parole. His lawyers argued mefloquine was a factor. During his combat deployments, Bales had taken mefloquine, but it had never been entered into his medical records. He had also suffered a traumatic brain injury during his last Iraq deployment in 2009. Under the military's own policy, a prior TBI was supposed to be a contraindication for mefloquine, precisely because the drug crosses the blood-brain barrier and behaves unpredictably in a brain that's already been damaged. The policy said don't give this drug to someone with a TBI. They gave it to him anyway, and they didn't document it. 1 month after the massacre, the FDA received an adverse event report from an anonymous pharmacist, noting that a patient on mefloquine had carried out the Kandahar killings, and that the patient had a prior TBI, the exact combination the military's own guidance said to avoid. The Army said there was no record of any mefloquine prescription. Whether mefloquine contributed to what Robert Bales did that night in Panjwai is something that no one can prove with certainty. The court never considered it. The Sanity Board never heard about the drug. What's certain is that the pattern, a TBI, a drug that shouldn't have been prescribed to someone with a TBI, and no documentation, fit exactly the framework that researchers and veterans had been trying to raise for years. In July 2013, the FDA had seen enough. It issued a black box warning on mefloquine, the strongest warning level it had. The language was explicit. The drug could cause permanent neurological and psychiatric damage, not temporary, not manageable with the right therapy, permanent. Damage that could persist long after the last dose. Within weeks, the Surgeon General's Office of Army Special Operations Command ordered roughly 25,000 soldiers, the Green Berets, Rangers, Civil Affairs soldiers, and Psychological Operations troops to stop taking mefloquine entirely. 24 years after the FDA had approved the drug, 24 years after the label had included warnings the military chose to ignore. Roche had already pulled the brand name Lariam from the U.S. market in 2009. Generic mefloquine remained available. The era of mandatory, widespread military use was over. The black box warning didn't fit what was already broken. Veterans who'd spent years being misdiagnosed now had confirmation that the FDA agreed with what they'd been saying. But the VA still required proof of exposure that many of them didn't have, because the military hadn't kept the records it was supposed to keep. The Quinism Foundation, which Dr. Nevin established in 2018, has been pushing the VA to add mefloquine screening to its standard toxic exposure work under the PACT Act. 2 questions is all it would take. Did you take this drug? And did you experience symptoms while you were on it? From those 2 questions, doctors could start separating combat PTSD from a physical drug injury that looks identical to it. The VA had moved slowly. Somewhere in this country right now, there are veterans who've been in therapy for years without getting better. Veterans with tinnitus that won't stop. Nightmares that won't quit. A kind of paranoia that doesn't respond to anything they've been given. Veterans whose medical records showed nothing about a drug they swallowed every single week while deployed, because the institution that gave it to them never wrote it down. Veterans whose families have watched them become someone they don't fully recognize. They didn't choose to take mefloquine. It wasn't an option they selected. It was an order. The Army built this drug. The Army distributed it for 24 years. The Army had the FDA warning label from the very first day, and the Army chose to ignore it. When the damage was done, the system that caused it became the same system those veterans had to fight to get any help from. That's not a coincidence. That's a pattern. I'm Dave. Thanks for watching. If this story matters to you, hit subscribe, drop a comment letting me know what this history means to you, and I'll see you in the next one.
Oh, Dave.